Hello, everyone. Happy Tuesday. I almost said Friday. Happy Tuesday of February 10th here in the great state of Minnesota, better city of Rochester. Great to be with you. Mike Ackerman here, genetic cardiologist at the Mayo Clinic, director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. But I greet you on behalf of Walker Fromm, our SADS CEO. As you know, replaced our previous one, Alice, and has been doing an amazing job. I just want you all to know that the SADS future has never looked brighter. Very delighted with what we're seeing taking shape, new ideas, and just Walker's leadership. So on behalf of him, greetings from the SADS Foundation. As you know, Sudden Arrhythmia Death Syndrome Foundation is your home for families with genetic heart rhythm diseases like long QT syndrome and CPVT. It's for genetic heart rhythm and heart muscle diseases like arrhythmogenic cardiomyopathy or ARVC. And if you come to us with those names, great. If you come to us because we haven't figured out your name or the doctors have not figured out the name of your syndrome or the cause of your sudden cardiac arrest or your family's tragedy of sudden cardiac death, hopefully you find this your home also. Let us know how we're doing. We're constantly trying to be that support that our families need and deserve, to give you the kind of confidence that we expect you to have you live with our tagline of live and thrive despite the diagnosis, whatever that diagnosis is, and not live in fear and anxiety about it. So much is happening that's good about these conditions that we're learning together, and just grateful that you would choose to join us on this different day. This is the only day I could fit in to be with you. And so this is your questions, my answers. I love this time for SADS Live 176. But before we look over to the sidebar to see your tight question for me to try my best to answer in real time, taking them from the top, remember, we just started in February. We're 10 days into National Heart Month. And so be part of it. You'll see some things from the SADS Foundation that you can do to engage, to increase community awareness, and so forth. So scrolling to the top, here we go. And I can't wait to see who's joined us. Thank you. Daniela, how much weight do I give to a family history when assessing risk in long QT syndrome? I love that start this episode with this question. It's really important. Reminder, when I answer these questions, I'm never speaking about you and your diagnosis or your situation directly. I cannot give personal medical advice. That would require a 90-minute visit of a new visit with you to actually do justice to the question presented. But I try to take the question, as we always do, and unpack some important insights about it. Hopefully those insights are important. The family history one is really important for long QT syndrome. Now, when we tell people, know your story, know your history, know your family history, that's so we have a good handle on how that entity is behaving through the family. And it turns out that family history is really important for your own personal risk for some diseases, and it's really not important as a forecast tool for other diseases. So for example, families with hypertrophic cardiomyopathy who mostly aren't with us, they're with the Hypertrophic Cardiomyopathy Association. For that disease, family history is really important to you, the patient next to that relative. In fact, it's one of the so-called canonical risk factors, biggies, that's used to decide how aggressive I should take care of you with HCM based upon your family history. If it's been tragic, then we tend to be more aggressive, for example. Whereas in long QT syndrome, we've known for a long time now that family history is not a personal risk factor, meaning whether it's good or bad, it hasn't done anything in anybody. That may or may not be good news for you. I have to judge the behavior of the long QT in your body, and I largely ignore, put blinders on to how it has behaved in other relatives who own the exact same genetic marker, which is fascinating scientifically. Why is that? Why does one disease, does the family history inform, guide, provide forecast values, whereas others, long QT, it doesn't really. So thanks, Daniela. Great start. And Karina is asking, is magnesium okay to take for patients 60 and over with LQT2? Also, is collagen safe? And this is a really good question, Karina. And if you are able to tap into the SADS archives of SADS Live, you can search. I think there's a searchable feature. If not, we need to create that for you, where you can look at previous lectures from SADS Live, discussions on supplements. We've done 2 at least in these first 176 episodes. But in general, magnesium is A-okay. So I have no concerns about taking magnesium. Now, do I need my long QT patients to be on magnesium supplement if they're an otherwise healthy person? No, I don't. In my own personal practice, I seldom recommend supplements. Where I have people be mindful of their magnesium health, their potassium health, is in the setting of sort of magnesium losing entities or potassium losing entities like the yucks, vomiting and diarrheal illnesses, where the body may not be holding on to those important electrolytes as much as they should. And there I might then have them supplement. But I have very few patients who are on a daily supplement. But magnesium is a supplement that a lot of people in their 60s and older take. I'm not there yet, getting close to that club, but I'm fine with, if you take it. I'm fine with collagen. There's no QT concerns regarding collagen. Jessica is asking, is it possible to have a long QT interval on the ECG but not have a gene or a genetic reason? I know medications can cause it temporarily, but will there be any other causes, stress, illnesses? What's the likelihood you will have long QT syndrome if you've ever shown it a couple of times, if you've only ever shown it a couple times? You're the first to show this. Jessica, I love your question. It's super important, and it's not very well handled in cardiology. So the first thing is, can I truly have congenital long QT syndrome, but my genetic test is negative? Yeah, absolutely. Now, it turns out among all of the conditions represented among our SADS families, the genetic test for long QT is absolutely the best, meaning if you truly have that condition, the genetic test catches the most of it, 90%. Whereas if you truly have Brugada syndrome, the genetic test only catches about 20%, indicating that, in fact, most of Brugada syndrome is going to turn out to not really be genetic, at least certainly not mono, one gene genetic cause. Our families with ARVC, the genetic test yield is about 50%. So in the setting of long QT syndrome, if a person has a negative genetic test because somebody thought they had long QT syndrome, that's where I pause and say, are we really, really sure that we're going to keep them labeled as long QT syndrome? How good was the ECG, EKG evidence to begin with? And it turns out in our program, the most common reason for genotype negative long QT syndrome is that they don't even have long QT syndrome. They were overdiagnosed in the first place. So whenever a genetic test for long QT that rules out 90% of that disease all by itself comes back negative, the objective electrocardiographic evidence from EKG, Holter, stress testing, family story better be really convincing. Now, do I have cases that are no doubt long QT syndrome with a negative genetic test? Absolutely. And there we work to try to find that family's novel cause, because we're convinced that they really are part of that 10% remnant of genetically elusive or currently negative genetic test long QT syndrome. Now, if your test is negative, we do look and say, why is your ECG long? Is it really long? Sometimes it's been overdiagnosed, and so maybe that becomes easy. Maybe it's not long at all. But let's say the ECG finding is robust, legit, and there is abnormal QT prolongation. Well, then there's lots of reasons for that, as you mentioned. Medicines that you might be on, supplements that you might be taking, as in there's one that was popular for a while, cesium chloride. Might be a naturopathic agent, but the QT interval hates it. And so that can cause cesium-induced QT prolongations. Lots of diseases can do it as well. So it can be a byproduct of that health issue or that health disruption. So for example, diabetics have longer QT intervals than non-diabetics and so forth. There's a long list of medicines, 100 plus FDA approved medicines that can prolong the QT interval. There's a lot of electrolyte abnormalities, low body potassium can do it. There's a lot of health disruptions, diseases, whereas a byproduct of the disease, the QT can be longer than normal. So we need to look at your data very carefully, and hopefully somebody is doing that. A reminder, National Heart Month. You can help go online to the SADS and look at the information. Great information there. Malgrazata, I love that name. Greetings. Is a Holter monitor appropriate for accurate QTC evaluation? Well, that's another good question. We've written papers about that. The way I use the 24 ambulatory Holter almost has nothing to do with the QT measurement. I don't use it for making the diagnosis, have almost never rendered the diagnosis of long QT syndrome when the ECG treadmill or genetic test did not nail or enable the diagnosis. So I use Holter to see if by chance there's unacceptable background ventricular ectopy, bad beats, irregular beats, skip beats. If by chance I've overdosed the beta blocker and I'm driving their low heart rate or the minimum heart rate too slow and contributing to potentially symptomatic slow heart rate. So I use that as a safety check for optimizing, titrating the beta blocker. Almost never have I used it for the diagnosis. And in fact, when asked if I were forced to cancel one test, and I would not think it would impair my ability to take care of my long QT families, it actually would be the Holter. Now, I like it. It does feel like it gives me information, but compared to the other tests outperform it. So if insurance were ever to force me to cancel a test, that would probably be the first one on my removal list. Kim is sharing with me that we're going to shift over, that her daughter has Brugada pattern, and she's non-symptomatic, so never had a symptom, has a cold with low-grade fever that I am treating, but she flies out Friday. I'm a little concerned about her flying, or about her flying thoughts. So maybe it's about her flying and then you're asking me my thoughts. If she's having flying thoughts, then maybe we have to see somebody else. Just kidding. So I would say in this setting, and again, not direct advice for your daughter, is I don't fear fever in people who truly have Brugada syndrome. To me, the fever recommendation is a call to prevention and action, meaning when my children got fever, I said, yeah, who cares? And they said, but Dad, I really have high fever. Yeah, who cares? And then it's 105. Okay, take Tylenol. Whereas in patients with Brugada, where we know that fever can bring out the Brugada pattern or magnify, accentuate the Brugada pattern, it makes only sense to lower it. And so I tell my families that if the temperature register is 101.5 or higher, good enough, high enough, just treat with your favorite fever lowering medication, whether that's acetaminophen, trade name Tylenol, whether it's ibuprofen, whatever you prefer, and lower that. So if she has a low grade fever and she's on taking the Tylenol, there's nothing about flying or a compression chamber at 15,000 foot altitude in terms of how the airplane is compressed, if you will, that is Brugada agitating. So I'm not worried about flying in my Brugada patients at all. Deza is asking about a connection to dangerously low blood sugar and propranolol in children. And that's a wonderful question. We've published on this and showed there's a fascinating story behind that discovery of how rarely beta blockers in long QT kids, mostly LQT1 and LQT2 children, almost never LQT3, why they can have a low blood sugar reaction. Because it turns out that we've treated thousands of kids with so-called SVT with propranolol. There's also I think it's like a capillary hemangioma kind of thing that's treated with propranolol, and many toddlers, infants, children have been treated, and they don't show this low blood sugar side effect, but rarely long QT kids do. And it turns out that the LQT1 gene and the LQT2 gene expresses its encoded protein, that ion channel, not only in the heart, but also in the pancreas. And in the beta islet cells where insulin is secreted. And so that potassium channel abnormality in the pancreas causes a very mild, very minor sugar glucose control glitch. Almost always, it doesn't matter, doesn't matter at all. But if it's in a stressed individual with lower glycogen reserves, then that propranolol reaction can show itself. And we showed that in patients, we had about 5 or 6 severe low blood sugar seizures in the setting of beta blocker, propranolol or nadolol. It really doesn't matter. And then we've almost never seen it since. And that's because we started making people aware about if your child is sick and not taking their nutrition at night and skipping meals, maybe it would be reasonable to skip the beta blocker that night, because almost always these occurred in children under the age of 5, so still tiny, not feeling well, so with a little bit of the crud, didn't eat the night before, but then took their medicine anyway. And then by morning, their sugar had bottomed out. And now that we just have improved awareness, we almost never see this low blood sugar phenomenon. But we really gave some insights into why do we rarely see it in long QT, but we never see it in children treated with propranolol with other conditions. And now you know the why. John is sharing that his daughter recently diagnosed with CPVT after she survived a sudden cardiac arrest. Very thankful for that part, and states that it is genetically RYR2, the gene that builds the ryanodine receptor, shares that mutation. Doing very well on nadolol and flecainide and a Medtronic Link 2. Question is regarding Artemis and other potential therapies. How is that going? Is there anything else coming up? Thanks for all we do. Great question. And so Artemis is one trial. As you know, there were 3 trials clinically available to patients. One was a drug from a company, Armgo Pharma. That trial was abandoned, discontinued, so that's not available. There is a trial, and it's on the SADS website, for a different medication, a different drug from a company, Cardurian. We are not enrolling patients in that trial, have not been approached to do so. But then there's the Artemis trial. The Artemis trial is from the company Solid Biosciences, and it would be the first gene therapy trial for CPVT. Incredibly exciting. I'm involved. I'm part of the advisory board for at Mayo Clinic's the first activated trial site for that. We have not infused the first patient yet. It's all getting underway. The trial was activated just last month. It's for CPVT patients with an RYR2 mutation. You have to be 18 and older. And I think just today, the SADS Foundation put out an email about Artemis trial. And so if your daughter is old enough, then she might be study eligible, but you'd have to just look at the various eligibility criteria. But gene therapy, these trials of gene therapy trials in heart for genetic heart diseases, and we have several of them for our families represented by the SADS Foundation, our PKP2 families, they are aware that there's not one, not two, but 3 gene therapy trials by 3 different sponsors for PKP2. Incredibly exciting. Early results have been published, but all of these trials are safety trials. They're not designed to prove efficacy. They're designed to prove that they are safe enough to be able to proceed with the larger, what's called the pivotal trial, to show safety and therapeutic efficacy parameters. So some families want to be part of the early wave of these safety trials. Others would be in the background saying, I think I'll keep an eye on the progress. I'm excited about the progress, but we'll have other families lead the charge. Great question. And we did that one from Kim, so I'm going to pass that. So I'm not skipping. I did that one already. Amanda's heard that green tea is unsafe for those with long QT. Can I comment on this? I'm not sure where that comes from. I'm not concerned about green tea in standard levels, just like I'm not concerned about caffeine, a grande or less pistachio latte. This one happens to be Starbucks, or of that region. I am concerned about highly caffeinated energy drinks that are blended with other chemicals in Monster, Red Bull, and Celsius, for example. And we've published some tragedies from that. It's not by itself offensive, but it could be part of the perfect storm. And so I have patients minimize their caffeine, not eliminate it, of course. And then, but green tea, I'm okay with that. I've never had a reason not to be. I don't drink green tea, although my wife says London Fog is an amazing tea drink. So it must be good. Dominique is sharing that is having a very low heart rate a concern for beta blockers as a treatment. It can be. So, and that's a really important question. If somebody has a naturally low heart rate, say they're fit, athletic, or just have good vagal tone, and it's starting in the 50s or 40s, will I be able to get the desired dose of the preferred starting medication, a beta blocker for long QT or a beta blocker for CPVT? Will I be able to get that introduced and up titrated to the level I want before I'm causing a different problem called, thank you very much, you've driven my heart rate even lower, and now I'm having something called slow heart rate symptoms, fancy term for symptomatic sinus bradycardia. And so I do look at that and I wonder, and we do have patients where we're not able to get an achievable dose. I do have patients, mostly LQT1 patients, where we've switched away from the beta blocker towards one-time surgery with videoscopic left cardiac sympathetic denervation, sometimes because of side effects, sometimes because we couldn't even get the beta blocker to a reasonable dose. Natalie is asking about, can someone carrying the gene that passed it to the son not show symptoms and not show it on the EKG, but yet the son is showing it on everything? Is it up to that person to take medication or not? So very important there, Natalie, that exactly, that's what we talked about with long QT syndrome. For example, you could own the long QT syndrome and not show any electrical evidence that it's there, but then pass it on to a child, 50-50 chance, and that new owner of that exact same genetic marker, that disease causative variant, can show itself in that owner dramatically so. And so we have to study it in each owner independently. Now, there are certain mutations where if you inherit it, it will show it, and it'll show it no matter who owns it. Those are highly penetrant mutations, but there are others that are very, very variable, very host dependent, and that all of the other things about that person and his or her environment influence whether that disease can even show itself. We have that true in CPVT families, and many of you CPVT says, oh yeah, I know what he's talking about. I own the marker, but my treadmill stress test is perfect. But somebody else with the same marker has an ugly looking treadmill. Our ARVC families show it as well. I know this story well. They said, I own PKP2 and they're thinking about a transplant for me, but some of my other relatives, they're 56 years old and they were a triple sport athlete and they still don't show anything. So it's very common in this area. It's given rise to fascinating questions in the research laboratory, like why? Why is that the case? What is influencing or determining whether a mutation in one owner shows itself in an obvious way and in another relative you can't see it? What are some of those protective mechanisms? What are some of those permissive mechanisms? Nancy's asking if we can get an accurate genetic result from hairs saved from a deceased person. Well, I guess the gist of this means awful tragedy has occurred, and I'm so sorry for that loss. Unlike what you see on CSI, you can't pluck hair. Now, mine would be hard. I just got a haircut last night from my wife, who likes the London fog. But just hair doesn't have DNA. You have to pull a hair and get a follicle underneath the skin, and that has some potential source of DNA. So just like a hair clipping of a baby clipping and things, that will not have DNA, genetic material to be sequenced. Carr's asking if there's a peak age for boys to have symptoms, and this is specifically for a son who's 15 with type 2 long QT syndrome. And the whole boy thing, girl thing, what age, is also incredibly fascinating in these diseases. So Carr, it's a great question. And as it turns out, there's a very interesting sex hormone relationship in long QT. You see boys before puberty, before testosterone, are at much higher risk than girls pound for pound. When I say much higher, that doesn't mean they're at high risk. They're just higher than a girl. Whereas girls before puberty, in the setting of low estrogen or no estrogen, they're at lower risk. Now, it switches at puberty, at armpit hair, because the arrival of testosterone is QT friendly, whereas the arrival of estrogen and progesterone in a female is potentially QT agitating. And that's why in adolescence, I'm more concerned about an LQT to 15-year-old female than I am an LQT to 15-year-old male, all things considered. Now, if by chance this LQT2 male has a rip-roaring QTC, 550 milliseconds to throw out a number, I don't tell that family, look, no worries, testosterone's here, no problem. So you still have to look at all of the other factors, but all things considered equal, a 15-year-old male is at lower risk with his or her LQT2 marker than a 15-year-old female. In contrast, in Brugada, a 15-year-old male would be at higher risk, all things else considered equal, than a 15-year-old female. Fascinating to think through the intersection and interaction of our sex hormones of testosterone, estrogen, progesterone, and how those hormones impact the electrocardiogram, the electrical signature, the electricity of the heart. And a fun little fact, if I can share with you, is Mayo Clinic's artificial intelligence ECG program, one of the first AI ECG algorithms that was created in after adolescence. is one where the computer, can stare at the 12-lead ECG, just the electrical signals coming from that ECG, and tell me with a 100% certainty, basically, whether that ECG is coming from a male or coming from a female. And so even an ECG that looks to my eye exactly the same, the artificial intelligence brain staring at those 60,000 different unique signals on a 12-lead ECG, that sheet of paper, can tell you whether those electrical signals are emanating from a male or a female. Fascinating how that's all working. I guess that's the word of the day, isn't it? Fascinating. I'm going to stop at that word, at least for the rest of our 10 minutes and counting. Danica, next one in line, is asking if we can provide links for LQT5, family of 5 with sudden cardiac arrest. And Danica, you can certainly do a search in Google. Google Gemini would be a fantastic tool, and ask it to pull up papers about type 5 long QT syndrome, or LQT5. LQT5 is an uncommon subtype of long QT syndrome. So if LQT1 is about 35 to 40% of all of my families, LQT5 is about 1% of all of those families. So for every 35 LQT1 family, I might have one LQT5 family. Now, we benefit from LQT5 in the sense that the learnings of LQT1 apply to LQT5, because the LQT5 gene, KCNE1, not Q1, encodes a beta subunit to the same ion channel for which KCNQ1, the LQT1 gene, builds the so-called KV7.1 alpha subunit. So the LQT5 beta subunit affects the exact same channel, such that the behavior of LQT5 is very similar to the behavior of LQT1. In other words, we know that beta blockers, even though we don't have the same level of numbers of LQT5 families, we have the same mechanism to be able to conclude that beta blockers are extremely effective in LQT5. Denervation surgery is extremely effective in LQT5, for example. Joy is asking from the platform of Instagram. Hi, I've tested positive for Ajmaline. So I'm guessing Joy might be in Europe. Her brother, oh, I'm sorry. Your brother died last year suddenly at 23. Oh. And you have no symptoms of Brugada. Is it recommended I get an ICD? So again, I'll be careful that I'm not giving you a recommendation, but I'll tell you what how I approach this scenario. So first, we see that we don't know that the brother who died from Brugada syndrome, unless there's other evidence that he had an abnormal ECG during life, but we might be dealing with a sudden unexplained death of a relative, for which the guidelines tell us that all of the other relatives surrounding that tragic death, that deceased individual's siblings, in this case, Joy, that deceased individual's children, and that deceased individual's parents, those would be the collection of what are called first-degree relatives. And in that context, you get evaluated. And it sounds like in this case, that evaluation included Ajmaline testing. Now, that's a drug challenge test that's used to bring out the possibility of Brugada if it's there. It's not a perfect test. It's a good test. And in this case, it sounds like it brought out a finding in Joy's ECG. And that might be causing the people there to say, we now have figured it out. Joy's brother died from Brugada syndrome because look at what Joy's drug challenge test demonstrated. And that could be true, but it also means we have to be very careful. What's the evidence? Have we now gone on to do genetic testing to see if we can prove Brugada on a genetic basis? Not a perfect test. That test, if Brugada is really, really there, remember, we said at the very beginning, is going to come back positive about 20 to 25% of the time. But if it did come back positive, did we confirm it in the deceased? And then let's say we've done all of that. And now I know that somebody's died from Brugada, and now I have the Brugada marker, but I've never ever done anything. Do I need a defibrillator because what appears to have been the cause of death of my loved one? And just like we said at the beginning with long QT syndrome, family history in Brugada syndrome is not nothing, but it is a weak one. It's not a strong one. So in my practice, I do not install defibrillators in relatives of a Brugada decedent, even if I know Brugada was the cause. Now, if on the other hand, the living owner shows a Brugada pattern all the time, anytime you do an ECG, has fainted, oh yeah, they remembered a faint, or I don't like some other features of the ECG, well then almost independent of how it declared itself in the one who tragically died, I may be more likely to treat that person more aggressively. So again, by default, I would not just say, oh yeah, of course an ICD. Proceed very, very carefully. And it looks like in proceeding carefully, I'm going to have time for one final question from Lauren. Lauren, you get the final one of the day, and then we'll pick up where we left off. And Tegan's saying hello following it. So hi to Tegan. But back to Lauren. Lauren is sharing a statement first. The postpartum period is known to be high risk for type 2 women. What can be done to help prevent anything bad happening? Would hormone therapy like birth control be helpful in controlling drastic hormonal shifts? I love this question, and it's important to finish on this because I can encourage you that I think we've misled the long QT to community of women a little bit with this declaration of postpartum being high risk. This was a discovery pronounced now some almost 20 years ago when Arthur Moss, the late Arthur Moss, did a powerful and important study from the so-called long QT registry based out of New York. And in that, if you compare the event rate of women 40 weeks before they got pregnant, 40 weeks of pregnancy, and then the 40 weeks after they gave birth, postpartum, they showed that there were more events postpartum than there were during pregnancy or before conception. And that led to the pronouncement that postpartum is high risk. And I don't like that term. Is it higher risk than the state of pregnancy? Yes. Is it high risk? No. In fact, we have a very exciting, I think, encouraging paper coming out because that declaration of high risk almost always comes as the setting, the environment in which a long QT2 family got exposed. Because it turns out that this observation of the postpartum effect is almost exclusive to LQT2. Seldom ever observe it in LQT1, basically never in LQT3. So there's a sex hormone postpartum phenomenon that's more unique in its interaction with type 2 long QT syndrome. Fascinating. Oh, sorry. And then the but comes in that when we look at our families who have been diagnosed, risk stratified, treated for their LQT2, who then get pregnant and go postpartum, how often do we see LQT2 episodes? Almost never. So while it might be higher risk when we don't know the LQT2 is there, you're not diagnosed, you're not treated, that higher risk window of time is almost completely neutralized by having a person diagnosed and treated appropriately. So I do not fear women getting pregnant with LQT2 have a lot of children. I do not fear the postpartum phase. We navigate it. We take precautionary measures. We may up titrate therapy during that window of time. If we sort of lighten therapy beforehand, we may do some monitoring. But do I fear a woman entering the postpartum phase with their LQT2 genetic marker? Don't fear it. Don't fear it at all. And with that, we're at the top of this hour, and I leave you until next time. So live and thrive, and I will see you again on March 10. Just shift it from February 10 to March 10 on your calendar, and I will be back with you, and I can't wait.